There is something sitting in the medicine cabinet of almost every household in this country right now. Something most people reach for without a second thought. Something doctors hand out freely, pharmacists sell over the counter, and health guidelines have called safe for decades. And in my 2 decades of cardiac surgery, I have watched it quietly destroy the cardiovascular systems of patients who had no idea it was even a factor. I have opened the chest of patients whose blood pressure was completely resistant to medication. 2 drugs, 3 drugs, combinations that should have worked. And when we dug into the full picture, the answer was in a bottle of ibuprofen they'd been taking every single day for years. For a bad knee, for lower back pain, for arthritis. For the kind of chronic ache that just becomes part of life after a certain point. And nobody, not a single physician along the way, had connected that pill to the pressure reading on the monitor. So that is what we are going to talk about today. Not salt, not stress, not the usual list. We are going to talk about a specific class of medication that is raising blood pressure in tens of millions of people right now, and doing it in a way that makes it nearly impossible for your doctor to detect unless they know exactly what to look for. Let me start with what these drugs actually are, because the category is broader than most people realize. We are talking about NSAIDs, non-steroidal anti-inflammatory drugs. Ibuprofen, the one most people know by the brand name Advil or Motrin. Naproxen, sold as Aleve. Diclofenac, celecoxib, the prescription version. These drugs are taken by hundreds of millions of people worldwide. In the United States alone, roughly 30 billion doses of over-the-counter NSAIDs are consumed every single year. 30 billion. For pain relief, for inflammation, for fever. Trusted completely. Treated as harmless. Here's what your body is actually doing when you take one. NSAIDs work by blocking a specific enzyme in your body called COX-2. That enzyme produces prostaglandins, which are the compounds responsible for inflammation and pain signals. Block the enzyme, reduce the prostaglandins, and the pain goes down. That part is real. The drugs work exactly as described. The problem is that the same prostaglandins those drugs are suppressing also perform a completely separate function inside your kidneys that almost no one ever explains to you. Think of your kidneys as a pressure valve for the entire cardiovascular system. Under normal conditions, prostaglandins tell the small blood vessels inside your kidneys to stay open and relaxed. Wide open vessels mean blood flows freely, sodium gets filtered out efficiently, and fluid gets cleared from your body. Blood pressure stays in balance. It is a quiet, invisible process happening thousands of times per minute without you ever noticing. When you take an NSAID, you suppress those prostaglandins. The vessels inside your kidneys constrict. Blood flow to the kidneys drops. Your kidneys interpret that reduced flow as a signal that the body is under threat, possibly dehydrated, possibly in a low-pressure emergency, so they respond exactly the way they are designed to respond to that signal. They start retaining sodium. They hold fluid. They protect the body's blood volume by pulling everything inward and holding it tight. The result is the same as pouring extra water into a garden hose and then pinching the end shut. The pressure inside that hose has nowhere to go but up. And it does. Consistently. Measurably. Often dramatically. But there is a second layer to this mechanism that most explanations leave out entirely, and it matters. NSAIDs also block the production of a specific compound called prostacyclin in the walls of your blood vessels. Prostacyclin is one of your body's natural vasodilators. It tells the smooth muscle in your arterial walls to relax and stay open. Suppress prostacyclin, and those walls tighten. So, you are getting a double effect simultaneously. The kidneys are retaining sodium and fluid from one direction, and the arteries are constricting from another direction, both at the same time, both driven by the same pill. The blood pressure has no physiological escape route, and the reason this goes undetected for so long is that neither of these effects feels like anything. There is no signal. There is no symptom that specifically says the ibuprofen is doing this. The pressure just climbs, slowly, steadily, day after day, and gets attributed to stress, to age, to the natural progression of hypertension. The doctor adjusts the dose of your blood pressure medication. The NSAID keeps working against it in the background. The reading stays elevated. The cycle continues. Does that make the full mechanism clear? Because once you understand it, the next thing I'm about to show you becomes genuinely alarming. Here is the number that I think about every time a patient comes to me with resistant hypertension. Blood pressure that simply will not respond to medication. Studies across multiple independent research groups have found that regular NSAID use raises systolic blood pressure by an average of 3 to 5 points in the general population. That sounds modest, but in people who already have hypertension, the effect is larger. In older adults, it is larger still, and that average is masking something critical. Because for a significant portion of users, the elevation is not 3 to 5 points. It is 10, 15, even 20 points or more. In those individuals, the drug they are taking for pain is actively overwhelming the drug they are taking for their blood pressure. There was a landmark paper published in the British Medical Journal that examined the relationship between NSAID use and blood pressure across over 19,000 patients. The finding was unambiguous. Regular NSAID use was independently associated with a significantly increased risk of hypertension onset and a significantly decreased response to antihypertensive medication. The drugs were working against each other, and the patients in those studies were doing everything right, taking their prescriptions faithfully, watching their diet, following instructions. The NSAID was the variable that was never reviewed. A separate analysis published in the Archives of Internal Medicine looked specifically at women with normal blood pressure and found that those taking ibuprofen daily were 86% more likely to develop hypertension over a 4-year follow-up period compared to those who did not use it regularly. Not a slightly elevated risk. 86% in women who had perfectly normal readings at the start of the study. The drug was not just worsening existing hypertension, it was creating it in people who didn't yet have it. And a meta-analysis examining over 300,000 patients found that NSAIDs accounted for a meaningful and measurable proportion of cases of what clinicians call resistant hypertension. Blood pressure that simply does not respond adequately to 2 or more medications taken correctly. When you isolate the patients in that category and review their complete medication profiles, including over-the-counter use, NSAID involvement appears repeatedly. It is one of the most under-recognized and most reversible causes of treatment-resistant blood pressure in the entire clinical literature. Reversible. That is the word that matters. Stop the NSAID under proper medical guidance, and in a significant portion of those patients, the resistance resolves. Now, let me tell you about a patient I spent a long time thinking about after he left my care. He was 68 years old, retired, in reasonably good shape, not overweight, walking regularly, no smoking, very modest alcohol use. He had been on 2 blood pressure medications for 4 years. His cardiologist had adjusted the doses 3 times. His readings remained stubbornly in the range of 150 to 165 over 95 to 100, which is meaningfully elevated regardless of what else is going on. He came to see me after a transient ischemic attack, a mini-stroke, that had resolved without permanent damage but had frightened him and his family profoundly. When I sat down with him and went through everything, and I mean everything, not just the medication list, but the over-the-counter cabinet, the supplements, the weekly habits, he mentioned that he took ibuprofen most days, 400 milligrams in the morning, sometimes again in the afternoon, for a hip that had been bothering him for 2 years. He had mentioned it to his primary care doctor once and was told it was fine in moderation. He had been taking it daily ever since. We stopped the ibuprofen. We introduced an alternative pain management approach. His blood pressure dropped 18 points within 6 weeks. 18 points. Without changing either of his 2 existing blood pressure medications. The drug that was supposed to be irrelevant was the single biggest lever in his entire cardiovascular picture. And nobody had connected it. Not because his doctors were careless, because this conversation almost never happens in a 10-minute appointment when the focus is on the numbers and not on what's producing them. That story is not unusual. I have had versions of that conversation more times than I can count. Now, I want to be honest with you about something, because I think you deserve the full picture and not just the alarming half. Not everyone who takes ibuprofen occasionally is in danger. If you take a single dose for a headache or a sprained ankle, the effect on your blood pressure is real but temporary. It resolves when the drug clears your system. The risk profile that I am describing, the one that concerns me deeply, is the pattern of regular, ongoing use, daily or near daily, weeks, months, years. That is where the sustained kidney suppression creates sustained sodium retention. That is where blood pressure climbs and stays elevated. That is the pattern to examine, honestly. So let's talk about what is in your medicine cabinet right now, because there are some specific situations where the danger is considerably higher than most people understand. The first is the combination of NSAIDs with AC inhibitors, or ARBs. These are two of the most commonly prescribed blood pressure medications: lisinopril, ramipril, losartan, candesartan. If any of those names are on your prescription bottle, pay close attention. AC inhibitors and ARBs work in part by dilating the blood vessels inside the kidneys to improve sodium clearance. NSAIDs work by constricting those same vessels. They operate in direct opposition at exactly the same anatomical location. Taking them together long-term doesn't just reduce the effectiveness of your blood pressure medication. In some patients, particularly those with any underlying kidney vulnerability, the combination can accelerate kidney damage in a way that only becomes detectable months or years later. This combination has a clinical name in the literature. It is called the triple whammy when a diuretic is also involved. The name is informal, but the risk is documented and serious. The second hidden factor is ibuprofen taken with aspirin. Many people over 50 take a low-dose aspirin every day, 81 milligrams, on the advice of their doctor for cardiovascular protection. Here is something that surprises almost everyone who hears it. Ibuprofen and aspirin compete for the same binding site on a specific enzyme. When you take ibuprofen before or alongside your daily aspirin, the ibuprofen blocks aspirin's access to that site. The protective effect of the aspirin is significantly diminished or eliminated entirely. So the very medication you are taking to protect your heart is being canceled out by the painkiller you are taking for your knee. Take a moment to sit with that, because millions of people are in that situation right now and have no idea. The third situation is the combination of NSAIDs with diuretics, the water pills, hydrochlorothiazide, furosemide, drugs designed specifically to help your kidneys excrete sodium and reduce fluid volume to lower blood pressure. NSAIDs, as I explained earlier, tell your kidneys to hold sodium and fluid. These two drugs are working against each other in the most direct physiological sense possible. The diuretic is trying to open the valve. The NSAID is holding it shut. The net result is that patients on both are often getting far less cardiovascular protection from their prescribed medication than their doctor assumes they are receiving. Now, if you are in chronic pain, and this is genuinely important, please hear this clearly. I am not telling you to stop managing your pain. Untreated chronic pain has its own cardiovascular consequences. Chronic pain elevates cortisol, it disrupts sleep, it raises baseline sympathetic nervous system activity. All of those things also raise blood pressure. The goal is not to eliminate pain management. The goal is to have an honest, informed conversation with your physician about whether your current pain management approach is working against your cardiovascular treatment at the same time. Because there are alternatives, and most of them have never been discussed with you. Let me walk you through 3 specific things you can do starting today. These are not complicated. None of them require a prescription. All 3 of them can happen before your next doctor's appointment. First, take a full inventory of everything you take that isn't prescribed, not just the obvious pills. Topical gels containing diclofenac like Voltaren. Cold and flu medications, many contain ibuprofen as one of several active ingredients. Even some dental pain products. Write them all down. Specifically, write down the name, the dose, and roughly how often you take it. That list is your agenda for the next conversation with your doctor. Most physicians are not asking about over-the-counter, NSAID use at routine appointments, because the assumption is that over-the-counter means safe and irrelevant. That assumption is costing patients in ways that don't show up until significant damage has accumulated. Second, look at the exact medications listed on your prescription bottles tonight. If you see lisinopril, ramipril, enalapril, losartan, condosartan, or valsartan on that list, those are ACE inhibitors or ARBs, and you are also taking any NSAID regularly, write down this question and bring it to your next appointment. Is there a cardiovascular risk from combining my blood pressure medication with regular ibuprofen or naproxen use? That specific question, asked by name, will open a clinical conversation that almost never happens otherwise. It will take your doctor 30 seconds to answer, and the answer may change your treatment entirely. Third, ask your doctor about alternatives, because they exist and they are genuinely effective for many types of chronic pain. Acetaminophen, paracetamol, does not carry the same blood pressure mechanism. It is not perfect for every type of pain, and it carries its own risks at high doses. But for many people with chronic joint or back pain, it is a far safer cardiovascular choice than daily ibuprofen. Topical options: applying the medication directly to the affected area rather than ingesting it systemically, reduce the whole body exposure significantly. Certain physiotherapy approaches, certain nerve-targeted interventions, and in some cases low-dose naltrexone protocols have shown real results for chronic inflammatory pain without the cardiovascular trade-off. These options exist. They are being used. They are just rarely the first conversation in a short appointment focused on the blood pressure number on the screen. I want to stop here and say something I think is important. I have been in operating rooms for over 2 decades. I have held hearts that should never have needed to be held. I have had conversations with families that no family should have to receive. And one of the things that stays with me, one of the things that I find genuinely difficult to let go of, is how often the contributing factor was something entirely mundane. Not a disease, not a genetic catastrophe, a daily habit. A pill taken without a second thought because it was sold without a prescription, and the bottle said it was safe for adults. You are not to blame for this. The label on the ibuprofen bottle does not say, "Caution, if you are on an NSAID inhibitor and a diuretic, this drug may be undermining both of them and raising your blood pressure at the same time." It should. It doesn't. The 10-minute appointment with your doctor was never designed to have this conversation, not because your doctor doesn't care, but because over-the-counter use falls below the threshold of what gets reviewed at a routine visit focused on a prescription list. That is a gap in the system, and you are the one living inside that gap. But now you know exactly what is in it. Now you have the specific question. Now you have the names to bring to the appointment. That changes everything. The patients who walk in with a list, who ask the informed question, who say, "I want to talk about whether my daily ibuprofen is affecting my blood pressure reading," those patients get a different quality of care. Not because the physician is better, but because the conversation is different from the first word. Let me bring this all together because I want you leaving this video with something concrete, not just information. Here is the complete picture. NSAIDs suppress the prostaglandins that keep blood vessels inside your kidneys open. Constricted kidney vessels mean sodium retention. Retained sodium means elevated blood volume. Elevated blood volume means elevated blood pressure. That effect is real, it is dose-dependent, it is cumulative over time, and it is dramatically larger in people who already have hypertension or who are taking medications that operate on the same physiological pathways. The 3 highest risk combinations are NSAIDs with ACE inhibitors or ARBs, NSAIDs with daily aspirin, and NSAIDs with diuretics. If any of those apply to you, that conversation needs to happen. Your 3 steps: write down everything you take over the counter, including topical gels and combination cold medications. Review your prescription list tonight for ACE inhibitors, ARBs, and diuretics. And bring one specific question to your next appointment. Ask whether your pain management approach could be affecting your blood pressure medication's effectiveness. That is it. 3 things. 2 of them take less than 5 minutes. One of them is a single sentence at your next appointment. Now, I want to hear from you. Is there someone you care about who takes ibuprofen regularly and also manages blood pressure? A parent, a spouse, a close friend? Tell me in the comments and share this video with them. Not to alarm them, but because they deserve to walk into their next appointment knowing what question to ask. That question costs nothing. It takes 30 seconds, and it could change the trajectory of everything that follows. If this gave you something genuinely useful, hit the like button. It helps this information reach the people who need it most. And subscribe, because there is much more important ground to cover and we are nowhere near done. Take care of your heart. It has been doing its job faithfully, without rest, without complaint, for every year of your life. Give it the informed advocate it has always deserved. Everything I have shared today is general medical information based on current research and clinical experience. It is not personal medical advice. Your situation is unique. Your medications, your history, your specific conditions, all of that belongs in a conversation with a physician who knows your full picture. Please do not change or stop any medication on the basis of this video alone. Bring this information to your doctor and have that conversation. That is the whole point. Better information, better conversations, better outcomes.